Project, which I'm quite excited about, called Decreasing Delirium in Post-ICU and Post-Surgical Patients Admitted to the Medical Surgical with Telemetry Floor. Defined as a disruption in the normal neurochemical function of the brain, resulting in an abrupt change of mental status following surgery or an intensive care unit admission. Those are the most common medical situations leading to delirium, but there are other medical procedures that require sedation that can do this as well. Even oral surgery, something that you would not think of as leading to delirium. There are some theories about the cause of delirium being linked to the physiologic stress changing the way that the neurotransmitters are produced in the brain. There is also the fact that older adults, which are more commonly prone to delirium, having a weaker blood-brain barrier, making them more susceptible to chemical changes in the body. Risk factors for delirium onset include being over the age of 65, having a pre-existing memory issue, having a sensory impairment such as blindness or being hard of hearing, diabetes, and smoking. The rate of delirium in an intensive care unit patient can be as high as 80%. So it is a significant issue. The onset of delirium can increase the cost of patient care. There's been several studies on this. All of them show an increase of cost, but there's a great difference in what they show. And you can see the range there from $806 to $24,000. But the take home is that the onset of delirium does increase cost to both the patient and the healthcare provider due to the fact that this is going to increase the length of stay. The onset of delirium can also proceed as high as 10% of dementia cases. So as high as 10% of these people may never recover their normal cognitive qualities. Patients who develop delirium have a greater incidence of mortality both in the hospital and after they leave the hospital. This statistic has not changed much in 30 years despite all our efforts at treating delirium with mostly pharmacological methods. Problem: many patients experience delirium after an ICU stay or a surgical procedure. I have seen these surgical patients. I see them before their surgery, where they are feisty and cognizant. They know what day it is, what time it is. They go for hip surgery, they come back, they don't even know they're in the hospital. We don't really have a policy of ways to treat these patients with nursing interventions. I use the 5 Why method to find the root cause of our lack of treatment of delirium in the med-surg unit. We don't have any non-pharmacological treatments for delirium that we use on a regular basis. We don't really assess for delirium on a regular basis in the med-surg unit. We don't really have a knowledge of how to assess for delirium or knowledge of how to treat delirium with non-pharmacological methods. There is no requirement for assessment of delirium in the patients who come back to us from surgery, and there is no requirement for non-pharmacological treatment. I use the Iowa model to guide my project. If you follow my flowchart here, you can see that I was looking for non-pharmacological methods to treat delirium. As I did a literature search, one method stood out to me, and that is the method of music therapy. The reason this stood out to me is because it is easy to implement, it's not very expensive, and training would be minimum. Also, the 3 studies that I found all used the same dose of music therapy, which was 2 60-minute sessions per day. Proposed solution. implementation of directed and specific music therapy intervention for identified cases of delirium or for patients at risk of delirium to include slow tempo music exposure in 60-minute doses twice a day, administered through our floor iPads using noise-canceling headphones. For my search question, the population is patients admitted to the medical surgical floor post-surgical or post-ICU. The outcome measure is delirium in these patients, and the intervention is the slow tempo music listening therapy. Literature search, I settled on 3 articles using the same intervention, which is the slow tempo music given in 2 daily doses, 1 hour each. The first article, Daly et al., was called The Effect of Music on Delirium, Pain, Sedation, and Anxiety in Patients Receiving Mechanical Ventilation in the Intensive Care Unit. This intervention was completed in Turkey in a medical ICU. Using the intervention discussed, they found that there were significant decreases in the severity of delirium, the severity of pain, the level of anxiety, the level of sedation needed for each patient, and the number of days needed for mechanical ventilation. These were all lower in the music therapy group with a p-value of 0.5. In my second article, Johnson et al., Music Intervention to Prevent Delirium Among Older Patients Admitted to a Trauma Intensive Care Unit and a Trauma Orthopedic Unit, using the same intervention, they found differences in the physiologic responses, such as heart rate and blood pressure, showing a more relaxed presentation rather than the normal stress presentation where these physiologic measures would be much higher. All the participants in this study screened free of dementia. In the final study, Kahn et al., Decreasing Delirium Through Music, a randomized trial. This study tested the same intervention. Its primary outcome was just to see is this acceptable to patients, and the secondary outcome was days of delirium. It found that the days of delirium were reduced in the slow tempo music therapy group, as well as Haldol, opioid, and antipsychotic use. They didn't find these reductions to be statistically significant, but each item measured was reduced. All 3 of these studies were randomized controlled trials. On this slide, you can see my budget, timeline, and resources. The budget for this project is not very high due to the fact that we could use streaming music, which is free, and we already have the iPads. The only thing we would need to account for is purchase of the headphones and staff training, which is actually a very short training. This could be completed between November and January, and we could evaluate the results of our treatment in January. On this slide, you can see some barriers to being able to implement this intervention and my strategies for overcoming these barriers. For example, funding. We could hold a bake sale and ask for donations. Another barrier is getting busy and forgetting to do the intervention. Some strategies for this is putting posters in the break room or talking it up at huddle. Another thing that we can do to stop people from just, not doing it because they don't see the benefit is we could highlight the success stories, which we will see during huddle, and make sure everybody knows about them. People tend to be resistant to change, but we could talk about this, talk about how they have to unfreeze or thaw out from the current practice, which is not doing this intervention, and eventually refreeze into the practice of completing this intervention on an automatic basis. You can see my next steps is to create a task force to refine this proposal, and I need to present the proposal to management, gather the playlist, which I would consult with a music therapist to do that, obtain the funding for this program, purchase the headphones, talk it up so everybody's excited about it. The more you get them excited, the more they're going to do it. They're going to look for opportunities to do it. I need to create the training, which will actually be very simple, implement the training, and then we will all complete the intervention and evaluate our results. And here are my resources. Thank you very much for listening to my presentation.